Welcome to the lecture on the knee joint and popliteal fossa. The knee joint is the articulation between the condyles of the femur and the condyles of the tibia, as well as the articulation between the patella and the femur. The knee joint is inherently unstable due to the poor meshing of the articular surfaces and the fact that the femoral shaft is not completely vertical. It actually is on an angle of approximately 5 to 15 degrees. The angle of the femoral shaft helps us to determine the Q angle of the knee. This is significant because the greater the Q angle, the greater the likelihood of having knee problems, especially patellofemoral knee problems. For males, a Q angle of 5 to 10 degrees would be considered normal. For females, a Q angle of 10 to 15 degrees is considered normal. The Q angle is greater in women due to the female pelvis being wider than the male pelvis. The Q angle is the angle that is formed at the mid-patella where two lines intersect. The first line is drawn from the anterior superior iliac spine to the mid-patella, and the second line is drawn from the mid-patella to the tibial tuberosity. Where these two lines meet forms the Q angle. Pause the lecture to take this opportunity to, in your lecture notes, draw in the Q angle. So draw a straight line from the ASIS to the mid-patella, and then another line from the mid-patella to the tibial tuberosity. This will form the Q angle. The knee joint is a synovial joint and has the largest capsule of any joint in the body. The joint capsule is unique in that it attaches to the margins of the articular surfaces of the tibia and femur on the lateral and posterior aspects. Anteriorly, the distal quadriceps femoris and the patella form the anterior component of the joint capsule. The knee joint gains strength and stability from its ligaments and muscles. Anteriorly, there is the quadriceps muscle and tendon that gives strength. Posteriorly, there are the tendons of the knee flexors, and then there's also the cruciate ligaments, the anterior cruciate and the posterior cruciate ligament, to give the knee its stability. The patella is embedded within the quadriceps tendon, thus considered a sesamoid bone. The patella increases the leverage of the quadriceps by increasing its angle of force. The patella also serves to protect the front of the knee joint. The knee joint has two collateral ligaments, the medial collateral ligament, known as the MCL, and the lateral collateral ligament, known as the LCL. These ligaments are taut when the knee is in the extended position and looser when the knee is in the flexed position. Therefore, these ligaments prevent rotation when the knee is extended and limit rotation or allow some rotation when the knee is flexed. The medial collateral ligament is attached to the condyle, actually the medial condyle of the femur, and the shaft of the medial aspect of the tibia. The deeper portion of the medial collateral ligament is actually a thickening of the joint capsule, which is also attached to the medial meniscus. Therefore, it is often common to see MCL and medial meniscus injuries that occur together. The medial collateral ligament prevents knee abduction. The lateral collateral ligament is considered extracapsular and not part of the joint capsule. It lies deep to the IT band and deep to the biceps femoris. The lateral collateral ligament also blends with the tendon of the biceps femoris. The lateral collateral ligament prevents adduction at the knee. Pause the lecture to draw in the lateral collateral ligament and the medial collateral ligament. The knee joint has two cruciate ligaments, the anterior cruciate ligament known as the ACL and the posterior cruciate ligament known as the PCL. These cruciate ligaments are named by the attachment of the ligament on the tibia. During development, the ACL and the PCL are attached to the tibia in close proximity to each other and are attached more so on the posterior aspect of the tibial plateau. As the intercondylar eminence forms, the ACL attaches to the anterior aspect of the intercondylar eminence, whereas the PCL attaches to the posterior aspect of the intercondylar eminence. The ACL and the PCL are considered intra-articular or intracapsular, but extrasynovial because they lie between the fibrous joint capsule and the synovial membrane. These ligaments tighten to stabilize the knee in full extension. The ACL is attached to the lateral femoral condyle and the anterior intercondylar eminence of the tibia. The ACL prevents anterior displacement of the tibia or posterior displacement of the femur. The PCL is attached to the medial femoral condyle and the posterior intercondylar eminence of the tibia. The PCL prevents posterior displacement of the tibia or anterior displacement of the femur. This slide depicts the development of the ACL and the PCL as the intercondylar eminence is developing. On the left-hand side, you have a superior view of the tibial condyles with the ACL depicted in red and the PCL depicted in blue. Initially, these two tendons are close together on the posterior aspect. As the intercondylar eminence develops, they separate further apart and the ACL attaches to the anterior intercondylar eminence, whereas the PCL attaches to the posterior intercondylar eminence. Also note here that the outer circle around the condyles is the fibrous joint capsule, whereas the inner circle is the synovial membrane. So you can see here that the ACL and the PCL are intracapsular but extrasynovial. Pause the lecture to draw in the anterior and posterior cruciate ligaments. In this drawing, the red is depicting the anterior cruciate ligament, whereas the blue is depicting the posterior cruciate ligament. The drawing on the left is a superior view, whereas the drawing on the right is an anterior view with the knee in the flexed position. These links have good anterior and posterior views of the cruciate ligaments. The menisci are crescent-shaped pieces of fibrocartilage attached on the outside edges of the tibial condyles. They move during flexion and extension of the knee, helping to improve the congruency of the tibial and condyles, giving the knee some stability. The menisci help to lubricate the joint and enhance rotation. They are also wedge-shaped with the thicker portion on the outside, and they get thinner as they go deeper in toward the center of the joint. The periphery is well vascularized, therefore it is able to heal if there is a small tear on the outer edge of the meniscus, but if the tear goes further into the meniscus where the vascularization is poor, there is poor healing. The lateral meniscus is almost O-shaped, whereas the medial meniscus is C-shaped. The medial meniscus, as mentioned before, is attached to the medial collateral ligament. The knee joint is considered a modified hinge joint because there is a small amount of rotation that actually occurs in the knee joint during knee flexion and extension. Because this movement cannot occur independently, is not considered a true movement in and of itself. The rotation actually occurs only when the knee is in the flexed position and occurs when the knee is going into a locked or unlocked position. We call this rotation spin. Because the medial condyle is longer than that of the lateral condyle, it has more surface area for articulation to occur. So during open chain knee extension, the tibia will actually rotate laterally into a locked position at full knee extension. No muscle is required to perform this spin or lateral rotation of the tibia on the femur. Again, this occurs because the medial condyle is longer than of the lateral condyle. In order for the knee to unlock, this does require the contraction of the popliteus muscle. The popliteus muscle will contract during flexion of the knee to medially rotate the tibia on the femur. The popliteus muscle is found deep on the posterior aspect of the knee joint. Its attachments are the lateral femoral condyle and the soleal or popliteal line of the tibia. Its actions are to internally rotate the tibia and also flex the knee. The innervation of popliteus is the tibial nerve. Pause the lecture to draw on the attachments and the muscle belly of popliteus. How does your drawing compare? Now let's talk about the vasculature of the knee. The femoral artery courses posteriorly through the adductor hiatus and is then renamed the popliteal artery. The popliteal artery gives off 4 major branches, forming an arterial anastomosis supplying blood to the knee. The 4 major branches are the medial superior genicular artery, the lateral superior genicular artery, the medial inferior genicular artery, and the lateral inferior genicular artery. The popliteal artery then branches into the anterior and posterior tibial arteries. These arteries continue to course distally into the lower leg. Pause the lecture to study the vasculature of the knee. Note the anastomosis, or the interconnection, of the medial and lateral superior genicular arteries with the medial and lateral inferior genicular arteries. This slide further demonstrates how the popliteal artery branches into the anterior and posterior tibial arteries. Now let's talk about some common knee deformities. Genu valgum, also known as knock-kneed, is a condition where the knees are angled inward, so when the person is standing tall, the knees are actually touching. This condition, if not corrected through bracing or foot orthoses, can cause chronic knee pain, including osteoarthritis. It is normal to see genu valgum in children ages 2 through 5, but as they develop, this deformity actually goes away. Genu varum is the outward angling or bowing of the legs. The chief cause of genu varum is rickets. Rickets is a vitamin D deficiency, which is often seen in third world countries where there's malnutrition. If there is a vitamin D deficiency, the body cannot absorb calcium, and therefore this causes deformities within the bone. Genu recurvatum is a knee deformity where the knees are held in a hyperextended position. This is more common in women and in those with ligament laxity, or in those with knee joint muscle weakness. Take the opportunity to click on the links provided. Now let's talk about some common knee injuries. The terrible triad refers to injury to the knee involving complete or partial tearing of the medial collateral ligament, the medial meniscus, and the anterior cruciate ligament. An MCL tear is where the medial collateral ligament is completely or partially torn, and this is usually due to a lateral blow to the knee, causing the knee or the tibia to go into a valgus position. The MCL tear is tested with a valgus test or stress test. The laxity of the MCL is compared to the non-injured side. A lateral collateral ligament tear is just the opposite of a medial collateral tear, where there is torsion on the tibia so that the tibia adducts. The lateral collateral ligament is tested with a varus stress test, where you take the tibia and adduct it. An ACL tear is either the rupture or partial tearing of the anterior cruciate ligament. In these injuries, the tibia is brought into an anterior torsion and is also tested in this manner. So the patient is seated and the clinician would take the tibia and translate it anteriorly. Again, you would compare the injured side to the non-injured side. You will notice with an anterior drawer test, there will be laxity. With a PCL tear, the posterior collateral ligament is either completely torn or partially torn. In this injury, a posterior drawer test is done to again compare laxity of the injured to the non-injured side. With a posterior drawer test, the tibia is translated in a posterior direction when the patient is in the seated position. A posterior collateral ligament tear is often called a dashboard tear, because in motor vehicle accidents, if the knee is pressed up against the dashboard, it can push the tibia in that posterior direction, causing the tearing of the posterior collateral ligament.